chairing this session. We have two presenters. We have Dr. Simone Leroux, as well as Mr. Moses Isiagi, and I'm sure they are known to most of you guys. So our first speaker is going to be Dr. Simone Leroux. So I'm just going to give you a short um, bio on him. So Dr. Simone Leroux um, his background lies in anesthesia, where he has worked in rural and urban district hospitals. He has a particular interest in strengthening surgical capacity at district hospitals and is currently collaborating with numerous rural hospitals in the Eastern Cape within South Africa in an effort to reimagine ways of expanding surgical services offered to this extremely rural community. Most recently, he has co-founded the Anesthesia Launchpad, a simulation-based capacity building platform aimed at rural district hospital medical officers. The lack of anesthesia services is often a barrier to the rollout of surgical services in general. The Launchpad not only builds much needed capacity, but also brings together a community of like-minded medical officers and helps link them to their referral institutions. So his interests lie in anesthesia and surgical capacity building, particularly in rural district hospitals, using film and video to tell the story of global surgery on our continent, and through this medium to advocate for equitable access, safe, affordable, and timely surgical care. He also has interest in diplomacy, that is building partnerships and strengthening collaboration is the key to linking context experts to context experts, one of many invaluable assets mapping steps. So Simon, if you can share your presentation with us. So each speaker has about 25 minutes to speak, and we have about 5 minutes of questions. Okay.
Kazar, thank you very much. Apologies, my mic was on. Are you seeing my screen?
Not yet, not yet. Yes, now I can see it.
Fantastic. Great. All right, good afternoon, everybody, and so thank you for the introduction. I need to send you a shorter one in future. It's very awkward listening to somebody talk about you that long. But thank you for everybody for being here. Kazan, I met at one of those district hospitals when he was a MO in the reg in orthopedics at Vic. And it's nice to be on this platform with him and with the rest of you. And I'm also really looking forward to hearing what Moses has to say after me. I've been asked to chat a bit about rural surgery, and it's interesting. I mean, it's a space that I've worked in a little bit. It's a space that I'm really passionate about, but it's hard to kind of sum up, what's important in 20 to 25 minutes. So I thought today I'd kind of just go through these three things and have us all reflect a bit on why is rural surgery compelling, and we'll touch a little bit on where we are at the moment. We'll talk a bit about the challenges and a way forward after that. And the third topic, a way forward, I think is something I'd like to kind of I'd like you to think about. And if we have some time at the end, I would really invite participation and discussion from all of you to see what you think. So since 2015, I'm preaching to the audience or to the choir here. We know that there's been an increase in recognition for the provision of essential and emergency surgical care within the whole global health spectrum. I'm not going to go into the numbers. I think most of you know those. But there's been a recognition that it is not this luxury that first world countries can get. And I'd like to say equally so, I'd like to state today that it's not a luxury that should just belong in Cape Town, but it's a human right that should also be accessible in the most rural of our healthcare system. There's more and more evidence that many of these emergency and elective surgical care packages can be provided at district hospitals and should be provided at district hospitals. And the case for the case for that is compelling. You know, the community benefits and other sectors of the healthcare have shown that outcomes are improved if we bring the care closer to the community. It reduces patients' out-of-pocket expenditure. It improves health-seeking behavior. And we often refer to that maternity diagram of you know, the 3 delay models of care, of delay in seeking care, delay in reaching care, and then you know, delay in actual receiving care. And I can't help stepping away from this image of somebody that gets to that point and gets to district hospital, but then they're actually not getting the care there, that they then kind of have to start the whole process again. They've got to stay overnight and sleep on a floor and get in a taxi and drive 5 hours to another hospital that has also got hundreds of people coming from other rural district hospitals, have to wait and often therefore get delayed and poor care. So yes, it not only has community benefits, it's got benefits for the system of decreasing burden on the transfer services and on the referral institutions themselves. I mean, I'd like to touch a little bit later on, you know, I think one of the barriers to surgery not being done in the periphery is that people in big centers are scared to let somebody else do it. They want to do it themselves. They feel they can do it the best. But what inevitably then happens is that the services in the bigger centers gets overwhelmed, and people don't get to the more complicated cases. They just have to move the queue. They just have to do those basic orthopedic fractures instead of doing joint replacements, for example. And this kind of decentralization of care, I believe, is really important to the health for both the bigger centers and the peripheral centers. And then there's a benefit to into community service and actually being able to use those skills, build skills, see some career progression. And there's variety in your work. You're not just pushing clinics. You get to do, you know, some theatre every now and again, and you get better outcomes for when those cases that inevitably land on your doorstep that you have to do. When you do them, there's actually hope that you have good outcomes, and that's really important. Just for mental health for our staff, young and old healthcare workers in rural hospitals. But where are we now? We're not there. We're in a very tiered system where the second and third level hospitals is where the surgery is concentrated. It's staffed by fully qualified surgeons, anesthetists, obstetricians, theatre staff, but also beyond that, the procurement staff, the management, the everything is kind of favoring the second and third level hospitals, where the district hospitals are kind of, it's very limited. It's staffed by general hospitals. Some hospitals have a family physician, some have a family physician that look after their hospital and 5 others. There might be some clinical associates around with skills, but invariably the training of the bunch of people at these hospitals is so variable, and it depends very much on who's around, who's got an interest in what, and who takes initiative, rather than that there being some particular type of regulatory oversight, checks and balances, or accountability. Now I want to look at 2 examples. One is perhaps slightly more elective, and one is more emergency of cases that are of types of cases that are occurring in rural areas, but that end up in big cities. So this is a compelling slide from Frere Orthopedics shared with me. It's the Vula app stats for the first half of this year. And you can see that they are getting quite a number of referrals from across the Eastern Cape province, but Butterworth Hospital in particular, the only hospital on the N2 between East London and Tata, refer an immense amount of patients to them. And we'll get back to a little bit more detail about this slide, but I do want to show you that that's a huge load that just Butterworth alone is putting on Frere, and it's a huge load that these hospitals are all putting on the transfer services, on the EMS, and I think we can probably talk a lot about preventable reasons for orthopedic injuries as well. But we'll talk a bit about this slide later. But this is emergency and elective procedures that are not being done at district hospitals, but that are being sent to a central hospital. And to reflect pregnancy, this is a pretty personal one for me, because when I was at the hospital, my wife had an ectopic, and we could get in a car and drive to a private institution, and it was fine. But we know that the case for many women in our country, young women. 119 died in the latest Southern Mothers Report 2017 to 2019, and 37% of those ectopic pregnancy deaths occurred at district hospitals, and it seems that up to 62% of cases didn't even see a theatre. And in this case, we suspect that is because patients or doctors' teams are too scared to take these patients to theatre. They're used to doing spinals for Caesars, and that's essentially it. The overwhelming anesthetic is spinals, because the overwhelming surgery being done at rural hospitals is Caesars, and that helps you to a certain point, but then it fails you. And we need to think about how we can remedy that. And 119 might not seem like a bigger number, but for me that's terrifying, that we are losing a lot of women unnecessarily. So what are the challenges of rural surgical care? Well, I think it starts in some ways with an ill-defined role of district hospitals in what they are supposed to be providing. So there have been many attempts at kind of doing lists by the World Bank, but these lists are, I think, quite in some ways fluffy and not particularly well defined locally or nationally. And we don't, if you sit at a district hospital, you're not sure, are you supposed to be doing ruptured ectopics? Okay, yeah, probably, because that patient will die if we don't do it. But are we supposed to be doing patients that are not ruptured? Are we supposed to be doing some orthopedics? And there's a lot of confusion about what is the basket of care for district hospital, for rural hospital surgery, and that's perpetuated by this notion of all the medical legal concerns. People rather send patients up to a higher level of care, even if it's not necessary, even if it's cases that could be done locally, because they are afraid of what will happen to them from a medical legal perspective, and they're unsure, and they're not held accountable. There are various reasons, but I think the medical legal aspect is a big one, and one needs to give in some ways permission and clarity around what is the role of the rural district hospital. There's also a lack of trained staff. We spoke about this. There needs to be a surgical provider, anesthesia provider, well-trained theatre staff, a recovery room. There needs to be all the systems in place of ordering your equipment and your medication, and all those things do need to be in place. And I think we need to remember that the skills at rural hospitals are incredibly variable. You can have a family medicine consultant that has done lots of orthopedics, and suddenly there's he brings in some skills and does some training. But ultimately, if he moves on, then that skill or that service collapses. So there's variability, and there's a lack of sustainability if there are any services at all. And I think that comes back to undergrad training as well. There's no standardized surgical obstetric anesthesia training across the medical schools and internships, because we don't really know what we're aiming for if we're preparing people for generalist work. We know that if they want to specialize, then they should go and find an MO job in that and write these exams and get there. But we're not preparing people to work in rural hospitals in the same way. They kind of have to figure it out on themselves, by themselves, and those skills are often self-taught. And we rely a lot individuals' kind of drive and enthusiasm. And I'm not sure if that is a way to sustain a system. All right, and then I think this is a pretty important one as well. Is that there's whoopsie daisy. I have just popped out of my. There we go. This is a pretty important one as well. Poor communication and relationships. So often these rural hospitals are immensely isolated and just trying to survive. To be honest, they are throwing sandbanks, the river's overflowing, and there's no chance to look up and look at different solutions. There's no chance to look up and look around you and see who else is in a similar situation. So there's poor communication between rural district hospitals and poor communication with and often poor relationships with the referral hospital, and it's hard to obtain advice. It's hard to find somebody you can send a patient to. There's delay in reaching a specialist by phone or by ambulance, and then this thing comes in. There's quite a lot of judgment, even if there are skills at a district hospital. There's fear of doing that procedure because it'll potentially lead to criticism or reprimand from a referral institution. And then, of course, the training is also limited by lack of formalized mentorship from specialists, or limited outreach, or limited in-reach opportunity. So are there solutions? Well, I think so. I think we need to it might be hard to find a basket of care that works for everybody everywhere, but I think there is a way of finding a basic procedural basket of care that is kind of locally put together in provinces and districts, and that is modified with the help of the local stakeholders and refined by yes, the surgeon specialists peripherally, centrally, and the managers, but I'd like to say also by the doctors at the hospital, nurses at those hospitals, the nurses in those theatres, and really importantly, in a voice that's often not heard, is the community. What are the perspectives of the community, and do they want to get burns care at a district hospital, or do they prefer to travel? Those kind of things are important to understand. And then to create a basket of care for hospitals. So I'd like to say, is a solution? Yes, let's adapt for the local context. Lack of trained staff is very much an issue, but we need to build those relationship support networks. We need to have incentives for staff to be retained at hospital, and of course, all of this needs money and political support. But I believe through local, targeted, context-relevant training and education, we can support hospitals to deliver on the on the requested basket of care. If the basket of care is clear, then we can support hospitals to reach those goals. And the health system is built on the relationship. So one needs to have buy-in, one needs to have consensus from all the stakeholders, and a system of funding to support in-reach and outreach. So relationships and networks are crucial. And I'm going to come a little bit soon to about, I know I'm making quite broad statements here about how easy it is to fix these things. These things are not easy to fix. If they were easy to fix, they would have been fixed a long time ago. But I do think this is where UCT global surgery, and I think our global surgery community in general, comes in. How can we help? Where can we support? Well, we need to collect data, and we need to understand the context and the systems to assist in defining those baskets of care for rural district hospitals. We need to through advocacy and diplomacy help guide and influence policymakers. And we need to support and educate future and current healthcare workers. And then there are various implementation strategies, be it through our anesthesia launchpad or leadership launchpad, or anything really that they need at rural hospitals. If we can find a way of bridging our skills and our community skills to rural hospital skills, then we can prove a concept and scale that in the context of academia, good research, and we can prove on pilot level what does work at rural district hospital level for surgical services, and then scale that, knowing that one needs to adapt from hospital to hospital, province to province. So I'd like to take us back to Frere Orthopedics. This is some more of the stats that they've collected through VULA, and VULA is one of those things that are so useful. So you can see here monthly what are the cases that come in, days of the week, which days of the weeks are busier, and as I mentioned, which hospitals are sending patients, which hospitals need more support. It tells you where the injuries are happening. It tells you where on the upper limb are the injuries happening, and that gives you just information to know how can we target, how can we support, be it from a preventative perspective or from expanding services at local hospitals. Where is the need the highest? Where do we get the best bang for buck? This type of information, I think, is out there, and we need to proactively start gathering it to make our interventions as cost effective as possible. The Frere team, for example, have said that, and I suspect this is quite conservative, but out of all those patients arriving, 10% of the patients could have been done at level 1 facilities. And I think that's important to mention, is that's 10% without really any surgical intervention. This is just EC intervention, joint dislocation, washouts, or POP, following up of patients. This is actually not any real surgical intervention. This is something that could happen tomorrow. It's not something that requires a C-arm or even a KY driver. And I think this type of information is really useful to help us motivate for funding and for decentralization of care. There are similar stats for ectopics. There are similar stats for burns. And I think using data like this makes any implementation of that data really, really quite powerful. So, in conclusion, yes, in many ways, I think rural healthcare, rural surgery is the cornerstone, and can be so powerful in help giving access to safe and surgery to our population. But we need to adapt. We need to get a basket of care that's specific and relevant and flexible to all the different settings in our country and beyond our borders. We need to train and motivate staff that their training and the work they're doing is context relevant and sustainable and multi-layered. And I keep coming back to this. I think relationships are so important. It's so crucial to get people working together and pulling in the same direction. There's so many good people doing good stuff. And again, I think that something I've seen through UCT Global Surgery is that opens up opportunities for that somehow people working in the traditional silos don't have access to. So that's my thoughts. Back over to you, Gitsai. Thank you very much.
Right. Thank you, Simon, for a nice presentation. So at the moment, I think we can take a few questions for the next 5 minutes. Thanks for keeping within the time limit. Do we have any questions for Simon? Okay, I'll probably ask. I just had one question pertaining even to your last slide. And there's a few slides, or one or two slides, that you were talking about networking and relationships. Wanted to find out, do you have any networks or relationships or stakeholders that you have partnered with to make this service delivery better? Simon, can you hear me? Hello?
Yes. Sorry.
Did you get the question?
No.
Okay, so I was saying, you on your last slide and maybe one or two slides within your presentation, you did talk about about connections and networks and relationships. So I wanted to find out from you, are there any like stakeholders or people that or people or organizations that you are networking with to improve your service, the service delivery?
Um, Kitsa, it's a very kind of individual approach. I think the trick is to find people that are champions. There's no point for
Simone, I think you're muted.
apologies.
Yeah.
Thank you for the question. I think the biggest issue, or the real thing, the way you build relationships is to approach local fans, find out what they're passionate about, what they need help with, and support them in that. I think that's been our where we've had success. That's kind of been the cornerstone of it. Is where we've worked with people that are passionate, that have got their own local stakeholder buy-in, and just support them. That's really been the most crucial way. I think don't arrive with a solution. As Lomi always says, look for what the local problem is and try and see if you can match it. Sometimes you'll be able to, and sometimes you won't. But I think if you're not the person that can support, then just looking around this room, there's always, I think we're very lucky with an incredible network of people at Critica and within the global surgery space, and invariably you will always find somebody that can help.
Okay. Any other burning questions for Simone? If there are no questions at the moment, what we can do is at the end after. Okay. Uh, Peter, there's a question. Go ahead.
Thanks, Simone. I thought that was very interesting. I'm looking carefully, and I didn't see that Jenny was on the call, but to me, the stats you presented just point to one completely dysfunctional hospital. Is that out of place?
I think yeah, I mean, we've both been to that hospital, Peter, and I suspect it is a multifactorial issue. It is a hospital that could be functioning better, but it's also a hospital that is, as I mentioned, on the N2, and as you know, has a massive trauma load from it being the only major hospital between Mthatha and East London, which is the busiest part of one of the worst roads. I think, if not the worst, the second worst road in the country. So it's hard for me to point fingers and say it's a completely dysfunctional hospital. But yes, does that point out to a hospital that needs support and help? No doubt.
Yeah, I hear you. I just sort of feel like we're working in silos here, pointing out that there are surgical and anesthetic issues in one hospital when it's hard to believe it isn't across the board that this is a red flagship of the province. But yeah, I'll keep out. Thanks.
No, I hear you. I'm not saying it is easy or that there aren't other factors at play. But I think it's interesting. This is a hospital with some key local champions. The classic example: Jenny Nash and Simongila Mandondo are two excellent district specialists that are really trying to turn a ship around. I think our role is to say, hey, how can we help you? And how can we support you? Yeah.
Okay, I think our 5 minutes are up. We'll move on to the next speaker. If we still have time and you still have any questions for Simone, then we can ask questions thereafter.
Thanks,
Right. Cool. Thanks, Simone, for a nice presentation. Right. Our next speaker is Mr. Moses Isiagi. He is an interdisciplinary scientist with a varied educational background. He completed his undergraduate degree in Uganda, and he studied sports science and obtained a Bachelor of Science in sports science with an honors. And he later went to University of Cape Town in South Africa and obtained a Bachelor of Science in Medicine with honors, as well as a Masters of Science in Medicine with a distinction in the Department of Exercise Science and Sports Medicine. He is currently a Masters of Science Global Surgery Research Fellow and Coordinator at Department of Surgery, Division of Global Surgery at University of Cape Town and Critical Care Hospital. Um, his research focuses on generating, translating, and scaling up evidence for reducing environmental health and social disparities, especially in low resource communities, and currently South Africa, particularly in factors affecting prevention, control, mitigation of chronic and acute non-communicable diseases in populations. So his interests lie in understanding relationships between the built environment and health, documenting and improving geospatial health disparities, and using and improving measures to quantify physical activity and relevant exposures, that is in social and built environment, using GSI accelerometry, GPS, and other new technologies. So Moses, you can start with your presentation. You see, you have 25 minutes of presentation and extra 5 minutes for questions.
Thank you. Thank you so much. Best feedback. Thank you so much. Okay, let's see.
There's still a lot of feedback.
Let me use Professor.
Okay. Let's just give Moses a few seconds. I think it's just relocating into another room. Oh, you're back.
I'm so sorry.
Okay. Do you any question? Oh, are you in, Moses?
Can you hear me?
In the meantime, if there are any questions directed to Simone, we can still ask whilst we're waiting for Moses.
Can you hear me?
Yeah, I can hear you.
Okay. Let me see if I can share my documents quickly.
Okay, thanks, Moses. Okay, I can see your presentation.
Okay, I'm just trying to see if you guys can see it.
Yeah, I can see it.
So sorry for the glitch. Are you able to see and follow with me?
Yeah, I can see your presentation, but you're currently on page 4.
On page 4.
Yes.
I'm on page 4. I think I'm using
Or slide
two
4 of your presentation. Yes.
slide 1.
So I can see your introductory page.
Okay,
Yeah.
I need to navigate because I'm using two spaces. There's one where I'm on. forgive me for the glitch, guys. I need to be able to. Hey, hi everyone. My name is Moses. Am I being heard?
Yes, I can hear you. You can go
Okay.
ahead.
Yeah. So mine really is my topic is geospatial determinants of health. How do we get there from an LMIC setting and a UCT global surgery lens? Because I'm kind of using two laptops. I'll be going in and out, and forgive me, I may take a lot of time, but let's just see how it goes from here. Okay. Yeah, so in essence, global surgery research interrogates both the unmet need for access to healthcare and a quality of surgical care with a focus on health system strengthening. Therefore, global surgery aims to find solutions to access of equitable care and an access to a comprehensive transdisciplinary surgical care. And with this, just merging it together from a global surgery place, we have three scientific priorities that we focus on. One of them would be providing essential surgeries in LMICs, and two would be strengthening the surgical systems, and three, we acknowledge that underlying medical conditions have an effect on surgical outcomes. I just wanted to find out if I'm on slide 2 from your side, because from my side, I can see I'm on slide 2. I'm on slide 2?
Yes, you're on slide 2.
Okay, and with the scientific priorities, we have three questions that rise from there, from a global surgery perspective. And the three questions would be, what is the state of the current surgical environment in LMICs? How can we optimize the conditions of surgery in this environment? And the third would be, how best can we bring about a system change to embed therapies for a universal care? Okay, and all this is really it falls under our research framework in Global Surgery Division, and the research framework reflects our responses to a dynamic, changing, and outside world and all its complexities, really. So that breaks down the research framework that we have. And this beautiful picture from a global surgery perspective shows what our research framework is. As I had noted before, we have three scientific priorities that we focus on, which would be essential surgeries, underlying health conditions, and surgical systems. If you move from the left side, moving to the right side, we see that there's a demand slide and there's a supply slide, and all these fall under the research questions which are above, the three which I had made mention before. And also, if you just focus down on the slide, you see the research lenses that we have from a global surgery division. And I'll focus on this later on and see how it links to my work. So the common themes that we really have from a global surgery research perspective is we see, or what I would say is that from a UCT global surgery perspective, we acknowledge that the critical role that innovations play in us just moving forward, and UCT Global Research Division or acknowledges the excellent research that you have. And under this, I would just bring your attention to the right side of it. We acknowledge that that these are the four things that we address from here. So the first would be the sustainable developmental goals. Two, we are looking at the SDHs, which would be the social determinants of health. And three, we look at the indicators of the Lancet Commission of Global Surgery. And four, we prioritize patient-centered care. And that's just a slide of the sustainable goals that we have. But yes, I had made mention before that I would focus on the research lenses that we have. Just looking at that, our research lenses somehow interact with the sustainable developmental goals, and these are the ones that we have from a global surgery perspective at UCT. So we see that there's access to surgical care. We see the patient and the community, acute and perioperative care. There's advocacy and policy in there. We look at cost and financing of surgical staff, AP. But literally for me, what I would want to focus on from a GS perspective is the social determinants of health. And all these fall under a theory of change, of which we also have assumptions to it. The assumptions that we have is we see the importance of a user-centered interdisciplinary approach to patient care, and we see that there is a need for coordination of activities to improve surgical care. And just moving along, we understand. So I'd say that I would focus on the social determinants of health. Embedded in the social determinants of health is what we call co-anxiety. And the explanation of co-anxiety is the chronic fear of environmental factors that are currently being experienced and that will likely have an impact on the community. And how does interlink would be the co-anxiety that we usually have from a social determinant point of view is we have a lack of access to surgical care. We see that it's expensive financing surgical staff. We see that the healthcare facilities are far, there are poor roads, there's poor advocacy, and there's no surgical care. And this is where the geospatial determinants of health fall in. So the geospatial determinants of health really are at work in multiple environments where we experience health, including the natural environment, the built environment, population connectivity environment, social and behavioral environment, and I'll explain all these as I move forward. So literally one would ask themselves, so what is a geospatial determinant of health? How does it fit in? And the explanation is, the need for a geospatial science in our lives is that our homes, our workplaces, our schools, the parks, our places of worship really affect the quality of health and the influence that it brings thereof. So geospatial science really, or GIS, provides important concepts, it provides methods, it provides tools in equipping public health scientists to examine, characterize, and analyze the important relationships between health and places in our lives. So just the purpose of geospatial determinants of health, which is a new thing that has just come up, is to define the geospatial drivers of health with an emphasis on factors that vary by place. An example I would give is between Langa and Pinelands is a 20-minute drive, but between Langa and Pinelands is a very big difference from a social economic point of view, from a health point of view, from and access to facilities point of view. And this is where the geospatial determinants of health come in. And the second purpose of geospatial determinants of health is they serve as a catalyst to define, to promote, and to advance the use of place in research and just practice across the public health community. Three, the third thing that, let me call them GDOH for now because it's a long acronym, they shape the public health curriculum of schools across Africa to advance geospatial analysis, statistics, in the study of public health. And I just wanted to bring to our attention that there also the GDOH has a lens, and the lens is fivefold. So the first lens that the GDOH has is a health policy environmental lens. The second one would be a population connectivity environment lens. The third would be a social and behavioral environment lens. And what the health policy environment lens brings to us is government at all levels enact place-based policies. And where we come in as a JS specialist is we further examine the impacts of health outcomes with GIS mapping and GIS analysis tools. From a population connectivity environment point of view, we see that our settlements, our behavior, and our connections with people and animals cause, intensify, and prolong the transmission of disease. And where we come in as a GDOH specialist is we use geospatial technology to provide visualizations to these interactions. And from a social and behavioral environmental lens, we see that each culture has a system of health beliefs which influence how they understand and seek out health information and make decisions. And where we come in, we still provide a lens and provide maps to this. And one that I really would like to focus on is the built environment part. We understand that the built environment is human-made and it's modified. And where we come in is we look at the various characteristics that the built environments provide, and these limit our access to healthcare, limit our access to healthy food, limit our access to clean water and safe spaces for physical activity. So literally, concluding what I wanted to present, just putting it out there that if you forget anything that I've said, the GDOH lens is a, just to break it down, is place is a broad and evolving concept, and the places that we stay in really impact our environment. So that's just the broader picture of what I would like to present to us. And just saying that the concepts and methods that we use from a GIS perspective really examine geospatial determinants, and these vary by place. And really, because it's a new niche, it's more from the built environment side. Where it intersects with us is it's almost like the geospatial determinants of health are a subset of the social determinants of health, but they really focus on the fivefold lenses that I'd given. And really, what I would say is what's the way forward from a global surgery point of view is moving forward. We want to train global surgery MSc fellows on geospatial thinking, which relates to the built environment and intersects with the social determinants of health. We need to get a registry for African regions. So from a GIS point of view, I would want to bring to our attention that the whole of Africa is actually using maps that are from NASA. And the difficulty in using those maps is we're actually not able to identify certain places. So we with the UCT Upper, they've developed maps for the entire South Africa, which speaks to a geospatial understanding of Earth, and from a bigger and broader point of view, at some point we would interact with African countries just to be able to provide layers and maps to grant truthing. And on the left side, what we really focus on is what we call walkability, which is in essence just a simple person in Umtata being able to have access to the various facilities that would provide to them. And from there, it's further built down into the four different themes that we see on the left. So the land use mix looks at how the environment is divided into various amenities like hospitals, schools, pubs, and the rest. So that's the land use mix, how we utilize our environment. The connectivity point of it speaks to our roads and systems and how people are actually able to get access to these amenities. The intersection density is a subset of connectivity. It also speaks to uh, people in various places being able to actually get the services. The transport density, breaking it down, still speaks to access, but it's threefold if you break it down further. And literally, where am I at now from a global surgery division? I'm really just focusing on a 5-year approach to developing a geospatial determinant of health lens here. So um, that would be the conclusion of what I've had to say. I'm seeing that we have run short of time. So yeah, I would like to really end there for now.
Moses, were you through with all your slides? I can see you're left with two more.
I was left with two more. So one is just really saying thank you. The other would be what I really want to focus on and just explaining what I'm doing from a GS point of view. Maybe I would focus on this just in a minute or so.
Okay, a minute or two is fine. Then we have about 3 minutes of questions. Then we conclude.
Yeah. So really, what I would want to do going forward is just bringing about the geospatial determinants of health view, because it's going to take time. It's interlinking what the built environment guys have with public health and the rest. So just in short, right now what I'm focusing on is I'm getting an activity framework, and I'm getting a detailed costing of what that would entail. Also focusing on a theory of, and just getting a developmental plan of how it's going to move forward from now for the next 5 years. So literally that would be me in short.
All
And
right,
I would
thank
like to
you.
say, yeah.
Yeah, you're done.
Yeah,
Sorry
so
okay.
that would be me saying a thank you to you all and for providing me this opportunity to be able to present.
All right, thank you, Moses, for your presentation, and we also like to thank Simone as well for their presentations. Do we have any questions for Moses or for Simone? This should be the time. I think we are left with maybe about 2 minutes of time.
Maybe just one quick question for Moses.
Mm.
Hi Moses, my name is Bruce. I was got a question around, you had a note in your slide there about providing a layer, I guess a geospatial or a GIS layer on a map showing all the surgical sites in South Africa. Would the intention of that be to, I guess, link access to those sites to different areas, and then to kind of map what access times or access distances look like to those sites? Or would you look at putting in some kind of density or other related metric for measuring, I guess, just access to surgery?
Yeah. Okay. So how I would answer that if so what we're looking at is being able to actually provide exact distances. So what GIS gives you is an approximate of where people stay. So when we geocode the places, we're actually able to get the accurate places, and that then means that from a radius of 5 kilometers, you're able to know what patient needs surgical care, what patient needs what at a critical time frame. And from an African point of view, the African terrains are different. So what GIS provides for example, if I'm to click a geocoding of my mother's village in Roux, Uganda, it would give you a different place, which is in Kampala. So from providing these layers, once we do it from an African point of view, we're actually able to get the different connections, and we're actually able to say, okay, now what population density do we have here? What regional density do we have here? How do we actually provide access to services to the people that need them from an accurate point of view than an approximate that has been used in high income countries to provide maps for Africa. So literally that's what the data registry means.
Okay, great, thanks. And is the long-term idea then to link that to the Lancet indicators for access to surgical sites?
Oh yes. So once you have that, then it means you can look at any outcome that you want. So you want to look at connectivity, then you're able to say, okay, now let's provide the roads here. If do you want to look at the transport density, it means, okay, now what modes of transport are we providing? Are we giving taxis? Are we giving public or private? So that's how it really connects. And also you're able to speak to the national government and telling it, okay, now you need to utilize your land well, because it gives you what we call a land use mix. So it's able to say, okay, now how many people stay here within a certain time frame. So that's how it connects.
Great, thank you.
Okay. Any one last question for Moses or for Simon? Okay, thanks to Moses and Simon once again for their presentations, and I would like to thank everyone for joining us in this meeting. I hope everyone gets to enjoy their weekend. I think this concludes our meeting. Thank you. Thank you all.
Thanks, Keziah. Thanks all.
Thank you, everyone.
Bye.